Okay. So thank you, double thanks to the double manos for the invitation, and let's go back to the biceps tenodesis. So it is a real life surgery, and I will. Could you cut the sound, please? Sorry, it's a keyhole technique. Maybe you don't know that, but it is a classical open technique imagined by an American surgeon in 1974. So the idea is to shape a keyhole into the bone, into the groove, and then you double the diameter of your tendon and you put inside, and the system will lock itself without any implant, without any screws. Of course, it is a cost-effective technique. So I will show you how it's possible to make it in routine under an arthroscopic procedure. So with the tension, you just have a locking system. So the patient is either in the B-chair position or in the lateral position as you want. You can see here the bicipital groove and the aponeurosis just onto the biceps. But before continuing the surgery, I would like to show you just around what happened around this area. So we are going to check the pec major anteriorly. We are going to check the conjoint tendon. We can check the subscap and all the brachial plexus if you want. In routine, it's useless, of course. This is the pec major. Then you go medially. It is a left shoulder. So you go medially, and then you can see the pec major. Then you can go under the pec major, and you can see medially the conjoint tendon, and you can go under the conjoint tendon. Of course, it's totally useless today, but just to show you the anatomy, you can see the subscap and the three sisters. You can see the brachial plexus if you want, and the lat dorsi just medially if you want to make a lat dorsi transfer. So you have to understand that I did not cut this movie. It is the normal time, so I did not want to cut anything to show you how it is. I've just doubled the speed of my surgery. The real time is 12 minutes, and this movie is only 6 minutes. So then now you go back and you are going to see where is the biceps. You just open the biceps, and you are just suprapectoral. You cut it with this needle. Sometimes you have some bleeding, of course. Why? Because you have bleeding over the groove, but you may have some vessels under the groove, and sometimes you have lots of inflammation, especially when you have a pathology into the groove. And this is one of the reasons why I think it's better to make a tenodesis into the groove, suprapectoral, than onto the humeral head. So after having opened the groove, this is the biceps, and you take out the biceps out from the body. And this is the only way, the only time when I cut the movie, because when it's out of the body, you just return the tendon on itself to double its diameter and to go in back again. So we are in again now, and you can see the conjoint tendon medially. So the idea is to continue the dissection of the groove, and it's very important to see the medial aspect of the groove and the lateral aspect, because when you will make your tunnel, it's very important to be exactly at the center part of the groove, of the was. You may have a fracture. I never had any fracture, but as you will drill with a 7mm drill, of course, you have to take care. So the goal is you are distal, now you are proximal, and you can see the half pipe. I call this the bobsleigh slope. In fact, it's a half pipe, and this is the wall, the medial wall of the bicipital groove, and your drill is you align the drill onto this groove, and the angulation of the drill is 45 degrees regarding the shaft, the direction of the shaft of the diaphysis. And then when you are happy with this Kirchner wire, you just drill around with a 7mm drill, because the diameter of your tendon, when you have double it, is 7mm most of the time. So you drill only the first cortex, not both the cortex, because you may have a risk of fracture again, and only 3 centimeters of deepness, because it is the thickness of your transfer. Then you with a system of loop, you loop, and then my Kerrison, my ronger, has a diameter of 3 millimeters. So that means the tunnel is 7 millimeters of diameter, and the keyhole, the distal part, is only 3 centimeters, and you have a real keyhole, and now it's very easy to fix your tendon. Now with the system of a loop, you pull back with you will see the blue loop, and with a shutter relay, you will take you see the blue one, so back to the body, and you will take now the biceps, of course. Then sometimes it's difficult to look for it because it's just under the pec major, but you can see that the purple sutures are very easy now to catch, and you can see what I've done with the biceps. So it's returned on itself. Then with this system of shutter relay, you pull back into the humerus, and then the idea is to pull into the biceps into the hole, but it cannot go in, so you have to take the biceps, to pull up, and then to penetrate it, otherwise it cannot lock. So with the big diameter, it can go inside, and then the system is self-locked, and it's very strong. And I've shown on my previous publication that with metallic marker that we have less failures than with intervention screw. Then I've just changed the portal to show you what is the aspect of the keyhole when you are with an anterior view, and you will see the groove, the biceps groove, then the 7 millimeters, and you can see the biceps into this groove, which is self-locked in self. This is done now. This is the final aspect of the tenodesis. Okay, thank you very much.